There we go. Thank you. Okay, we'll give everyone about 1 more minute and then we will begin. Okay, I think we can start. So hello and welcome to the first of many rural health series run by the Rural Seeds organisation. So before we begin this evening, I would like to acknowledge the traditional custodians of all the lands on which we're meeting on today and pay our respect to custodians past, present and emerging. So who are we? So Rural Seeds, or the World Rural Doctors in Training, is a network comprising largely of students and young doctors with an interest in rural medicine who collaborate closely with experienced doctors and other health professionals. The aim of Rural Seeds is to be a worldwide network that raises awareness and improves the guidance of training for rural practice for people in the early stages of their career development. One of its main aims is to contribute to the United Nations Sustainable Development Goals, especially goal number 10, to reduce inequality within and among countries. Since inequity in access to health services still persists around the world, particularly in rural areas. So before we begin, I will just talk a little bit about some housekeeping. So I'm sure many people are familiar with Teams. What I will get you to do is just make sure that unless you are asking a question, you stay on mute. If you have any issues with connection, that you either just sign out and try signing back in. If there are further questions, you can contact Rural Seeds at the bottom of the invite. And we will have time for some Q&A, but if you would like to use the chat function instead of asking the question, you can do that also. We'd like to make this as interactive as possible, so please feel very free to join the conversation and become part of it. So what is geographical narcissism? It's a very interesting topic that was actually brought about by a psychologist in Sweden who realised that there was a perception that things in the bush or in rural areas are slightly worse off than in the metropolitan areas or their metropolitan counterparts. And this perception and idea has infiltrated not just health, but many areas of industry, education, and other aspects of rural life, to the point that it can be linked to the reasons why rural health care is often disproportionately disadvantaged in terms of the workforce, recruitment, retention, and access of services by our rural communities. And it's been interrogated quite a lot recently by Bruce Chater, who's the chair of World Wonka. And it's become a very poignant discussion in the rural health space, which I look forward to hearing more about as we discuss this throughout our session tonight. So it brings me great pleasure to introduce our panel to you all this evening. So first up, we have Adjunct Professor Shelley Nolan. Shelley is the Chief Nursing and Midwifery Officer and the Australian Government Deputy Rural Health Commissioner for Nursing and Midwifery. She represents nurses at an international level as the International Councils of Nurses World Health Organization Western Pacific Region Nursing Lead. Shelley is also passionate about ensuring nursing and midwifery strategy provides sustainable and accessible nursing and midwifery care to regional and rural communities. And I look forward to hearing from Shelley as a fellow nurse myself, as we hear about some of the strategies that are in place, but also what's happening in the future of rural nursing in particular, as I think models of care will be changing a lot. So I'm very excited to have you on board. Thank you, Shelley. We also have Miss Kathy Hetherington. So Kath is the New South Wales Rural Doctors Network Service Delivery and Operations Manager. Kath's career spans over 30 years in health, aged care and community-based care services, having held senior executive, key management and leadership positions. Kath has worked with organisations and service providers who care for people and communities in urban, regional and rural settings across the spectrum of care environments, from prevention, promotion and early intervention in the population health space to palliative care and end-of-life care in the home, hospitals or residential facilities. Welcome, Kath. I look forward to hearing about your experiences, but also as a fellow New South Wales local, how you can add to this conversation as well. I'd also like to welcome Professor Michael Bryden. Professor Bryden is an experienced paediatrician with over 30 years clinical practice. He served as the Chief Executive of Sydney Children's Hospital Network until 2019 and is currently the Associate Dean of Rural Health at the University of Notre Dame Lithgow campus. Professor Bryden has received multiple awards for his service to the community, including an Order of Australia Medal for his contributions to child health in Australia. His additional interests and expertise are in the social determinants of health and Indigenous health issues. Thank you, Professor Bryden. And last but not least, JB, so Jean-Baptiste Philibert, who is a final year medical student at the University of Western Sydney. He has grown up across many places. So he was born in France, lived in Africa, and somehow found his way to Australia studying medicine and ended up loving rural health. JB is an academic representative on several faculty committees, listed on the Dean's Merit List, and is a recipient of several scholarships, including the prestigious New South Wales Rural Resident Medical Officer Cadetship, the John Flynn Placement Program, and the RACGP Rural Medical Student Award. So thank you so much, JB, for joining us. So as I've mentioned, we'll be discussing how understanding geographical narcissism is going to play a role in tackling the rural health crisis from an Australian perspective. I know we have a lot of international guests joining us today, and we'd love to have some of your learnings and stories join us throughout. But as I said, this will be from the experience of rural health in Australia, and we hope that we can share our experiences with you and see how we can work together in the future to tackle these things. So first up, I actually wanted to throw to you, Shelley, and I wanted to know a little bit about how you have witnessed geographical narcissism in your specific role. So whether you can elaborate on how you've seen this in the healthcare space or more so in your management, it would be really great. Thank you.
Thank you, Pippa, and welcome everyone. You know, the foundation of this is the notion that metropolitan experience is more valuable than rural experience is the root of this. And I think when we start to look at the components of our practice, regardless of what health profession that you're in, we really want to be able to break down that barrier that people who come from a city or even sometimes a really large regional area think that people that are working in the rural and remote settings aren't there because they've made it as a professional. And in some contexts, this I have witnessed where people even see that that's from their own individual, their own identity, their own selves, whereby they almost apologise to say, look, you know, I'm out in the sticks, I need your assistance from this perspective. But we know from research that this is actually a phenomenon that's obviously often subtle and unconscious, that people don't absolutely know they're aware of it when it's actually occurring at the point of time. And it comes to light in conversation generally, from my experience, where clinical staff are providing acute care or clinical care, and where the lead of that care is taken over by the metropolitan area. And that care provider becomes the lead rather than providing collaborative support direction to the acute care episode, whereby they should be supportive, they should be giving clinical advice and actually supporting a learning environment. In nursing and midwifery, we sometimes experience this when we're seeking a point of escalation of care, and all of a sudden your diagnostic assessment skills are being ignored or belittled, and all of a sudden in a telemedicine environment that care is taken over. The other example that I'd like to give is when it is assumed that you are less capable or less skilled than other clinicians, nurses or midwives that are working beside you. So it's those people who transition also to rural areas that have got this girth of experience in regional and urban areas, that all of a sudden working alongside of you on a day-to-day basis take the higher ground, that, you know, they have more knowledge and skill. I'll leave it there for the moment, Pip.
No, that's wonderful. Just for the interest of our international audience, would you be able to explain a little bit about, you speak of the metropolitan and the regional, and I'm assuming you're speaking in the context of Queensland, how these may differ just a little bit, just to give some context to the things you're saying?
So I'll give some experiences in Brazil. You know, we might be talking about Sao Paulo, where there's centralised care, and you may work and live in Três Lagoas, which is, you know, a smaller regional area, or a rural community that is agricultural in nature, industrial in nature, and a much smaller community. Here in Australia, we have a very, very large, diverse geographical area. But when I'm talking about that geographical narcissism, I'm talking about big cities and larger cities versus smaller country towns, and in our case, islands in the South Pacific, in the Torres Strait Islanders, where often the only care provider is a single nurse or a single doctor.
Yeah. It's a really interesting phenomena that this has been built on, the idea that obviously there are certain services that you need metropolitan resources for. We aren't going to have neurosurgery in, smaller locations. However, the idea that they are inferior to those areas is just ludicrous, that it has been continued down. And I think particularly among nurses, not only from rural to metro, but even within teams from a more regional site to a remote area, perhaps. Did anyone have anything they wanted to add to that? Perhaps, JB, you've seen some of these things when you did a bit of time in central parts of the Northern Territory.
Yeah, and actually my experience at medical school has been very relevant to that idea of geographical narcissism, and I was thinking about it today, and actually I've got two really good examples that have been quite recent. One of them is, so we had two of my friends applied for the same conference. They're working on the same project and they're going to present. One of them is rural, one of them is metro, on similar rotation in surgery. One of them was approved to make up the time on weekends and evenings in metro, but the one in rural wasn't approved because the hospital wasn't good enough. Even though it's a teaching hospital that has surgical trainees, so clearly there's enough experience, but just simply that idea from the metropolitan coordinator that happens. And then another example is that in our rural placement, we actually do, it's very integrated, very multidisciplinary. It actually meets the requirement for a lot of different rotation altogether. And so we actually end up, after our rural year at a university, meeting the requirement for one more rotation than the ones Metro have done. But the university doesn't let us take that extra time as an elective or to just do something more better. They just want us to just redo the rotation because we got to fit the Metro model. And I think it's a shame when we're actually seeing that the rural rotations are, better, or at least they are, you know, more expensive and more comprehensive than the ones in rural, in metro, then that's not being recognized. And that's a small example, and I'm sure it happens everywhere all the time, of, you know, where the differences are there, but they're not being recognized because the decision making tends to be coming from metro, and therefore it affects actually rural education as a result.
Yeah, interesting. You've raised a few very good points there. An interesting segue into sort of my next question around students and the future workforce space, but also interesting about where a lot of the decisions are being made and by who and in what circumstances, especially in regard to our rural and remote communities. So we'll come back to that. But on the role of universities and our future workforce, Professor Bryden, what role do you think our universities, whether it be Notre Dame or any of the others that you've worked alongside, have in overcoming geographical narcissism and the perceptions around what rural health can offer students and a future workforce?
Look, I'm going to paint a little bit of a picture, if that's okay. And I want to go back on my shift, which started as a medical student in the 70s. And in those days, you could only do medicine in a capital city. There was no option to go anywhere else. There were no rotations in the rural areas. You went to a capital city, did all your training in the capital, but there was this extraordinary good opportunity. If you were lucky in some of the courses, you got one elective. And so in my course, I got one elective and I went to one of the islands in the Pacific. So that was training. You didn't really get trained in rural areas. Some people came from the rural areas, but they were fully trained metro. And so you had this concept that that's where the action was. And a lot of people in my early generations stayed there. And partly they might have met partners because they were in those cities. They might have had an established, home or set up, but they'd finished their courses and a lot of them stayed in that metro environment. Isn't it wonderful that in the last couple of decades, particularly recently, that the system is starting to shift in a much more balanced approach? And so we're now starting to see part or all of your medical training being able to be supplied rurally. And I'll come back to it in a few minutes when we get a chance, but I actually think that's a better outcome. I think you get much better clinical exposure in a rural setting, much better. You're not in a queue to see a patient. You don't have, the fellow, the advanced trainee, the basic trainee, the intern. You don't actually get to talk to the senior person. You might get a look in at a patient. You certainly aren't close enough to an abdominal holding a retractor. Whereas in the rural areas, you're front and center. You actually may be the first assistant. You may be putting the cannulas in because there isn't anybody else, etc., etc. So you get all this fantastic experience firsthand dealing with real patients. And I think it's a wonderful shift in the dynamics. I'm not sure where this will all end up, but it's a new journey we're on to change this content of courses. And I think in the long run, it will start changing people's ideas about how and where to practice.
Definitely. That was my next question. I was going to throw one back and say, how do we change the dialogue around this? Is it by experience and having these, JB spoke of a rural year, you speak of like start to finish rural training, and whether that be medicine, nursing, other sort of allied health disciplines, how do we get that through? Is it just through the universities and talk of mouth, or is it through the role of a rural health commissioner and changing system things? It's a really interesting, a very complex conversation to be having. On that point, did you have anything to add, Shelley, from that perspective in Queensland?
Yeah, look, I absolutely agree with what Michael has said. You get so much more opportunity in rural, remote areas to work to your full scope of practice. And I think that is one of the things that is challenging around the experience that people have when they're supported at the same scope of practice versus when they're denied that scope of practice because they may be in rural, remote areas. And often this may be associated to the component where the funder, particularly if it's rural hospitals related to a larger regional hospital, may not see it worthy of providing the level of equipment and resources that they may have locally. And in fact, they probably could divert a lot more care back into community and primary health care if they had those pieces of equipment. We know now since COVID that life for everyone has changed in regards to virtual care. You know, the support that you get, even this conversation tonight with Teams, actually starts to break down the barriers and helping us make different policy decisions, particularly the focus on the sustainable development goals. And you know, we're back to actually saying, well, what's socially acceptable? What should we be supporting these communities? And we know that healthcare is the lifeblood and foundation of a community and the economics of that community, don't we? So, you know, I guess from a global health workforce shortage experienced at the moment, and it's most profoundly experienced in rural communities, we should have awareness around future policy that actually stimulates government investment in resources and rural, remote, generalist pathways for all, so that we can be focused on education and training as well as workforce planning and the management of how that's going to attract and retain people to keep viable collaboration with our healthcare and our teachers, our O resources, or our 911 resources for those people across the other side of the globe. It's just so crucial that we, you know, bring this inequity to an end.
Absolutely. No, that was very well said. I couldn't agree more. Yes, sorry, JB, jump in.
No, that's all good. Just on the topic of training and funding, which is where Shelley and Michael brought, which I find fascinating. I think Australia is really lucky. So we've got the Rural Health Multidisciplinary Training Program, which is quite well funded compared to other countries where we go. And as you mentioned, I have a rural year through my university, but now we're starting to see end-to-end programs, which I think is the next step in it, because the funding, I think at the moment, tends to target very much numbers. So, you know, you got to send X number of students in X number of rural locations to kind of meet your requirement, but it doesn't really look at the quality. And the quality of training is fantastic, but it's going to maybe kind of like disperse the funding and the training to everyone rather than, and I think we can admit that not everyone is going to be a rural practitioner. So I think making sure that we look after the people that are going to go rural and that express that interest early, and that they get as much experience as they can, so they can experience different communities and different settings and just become as good as they are. And I think there's also another aspect, which is to look after people that are rural, that maybe want to be neurosurgeons or maybe want to be, you know, highly specialized. And we understand that that's got to be done in the city. But then if those people are from rural, they're more likely to go back, even as, you know, visiting offices and all of that, doing outreach programs and all of that. So I think, you know, possibly basing people rural and then rotating them through the city for a year or something, rather than the other way around, where the idea is you need to be based in the city. When you're looking at, you know, preclinical nowadays, it's all done on Zoom anyway. So it doesn't matter where you are. Often you've got better connection, you know, in Bathurst than you have in Sydney. So those are all things I think that maybe funding in the future can consider to really kind of target that.
Absolutely.
Can I just ask JB a question, please, Pip?
Go for it.
JB, given your background with a lot of international experience prior to your medical degree, what do you think about this issue about previously all training was metro and now a possibility of all training be rural and a middle ground where you get a bit of both? Where do you think this will land in 20 years' time as being the best outcome for training?
That's a very interesting question. I think in terms of rural training, Australia is up there in terms of getting there. So I think the outcomes is we're looking at are here. And what we're doing at the moment, I think is working. So we do have practitioners and we do have people that are getting there, but it's clearly not enough. We need more. So I think yeah, and as I was saying, I think admitting and recognizing that you do need some time in the city for some things. If you're going to be, an obstetrician, you're going to do great obstetrics in the country, but you might not see the highly complex and specialized things that are going to make you that much better. And so I think having that experience in Metro, absolutely. But I heard a speech from Professor Paul Worley once that was saying that all training was based in the city because that's where the libraries were, but now the libraries everywhere. So I think that's where we can really go outside. And I think as long as we're not discounting the training in any way, I think as much rural experience as we can is really where it's at for the people that have that expression or that background or whatever. And I think I'm a good example of it. Obviously, I'm not from rural Australia, I'm from rural elsewhere, but I've expressed that intent very early on, and I've been extremely well supported through workforce agencies and universities and different programs that have sent me out as much as I wanted, which has been really cool.
Can I just add there, Pip, that, I think the rural exposure compared to metropolitan is you're not only learning from a medical officer to a medical student, you're actually learning from a multidisciplinary team.
Absolutely, yeah.
And we know that the multidisciplinary teams who learn and work together develop a more respectful relationship, deeper understanding of each other's roles, their scopes of practice and general understanding. And therefore, we actually get to the multidisciplinary nature of care, where the patient or the consumer is at the centre, and the individuals in the healthcare team not only know each other's skills, but trust and be open and collaborative to ensure that they're learning, and also troubleshooting when we do get these complex dynamic cases, particularly in industrialised rural cities and towns.
I couldn't agree more. And I think that the MDT benefits you have there lends also not just to the clinical, but to the community aspect, and what a role communities play in rural health, and really where the heart of rural health lies is looking after and being a caretaker for your community. And I think JB spoke about, positive placement experiences, and, whether that's through a 1 year end-to-end or a placement opportunity. The second greatest indicator of the likelihood of someone to go rural, the number one indicator is rural origin. We don't have enough rural origin people studying medicine, nursing, whatever, to replace ourselves or to address the workforce issue. And with the second greatest indicator being a positive placement experience, whether that's made up of clinical and community aspects, we know that we can, play a bigger role in showing that this isn't the, slightly worse off option because you didn't get a metro one. It's in fact one that is going to add to your clinical and your, experience as a clinician, but also provide incredible opportunities for your life, and whatever that looks like for partners, kids, and elements outside of that as well as making sure that you can set yourself up. With that, I actually wanted to make a bit of a deviation to Kath. I haven't forgotten you, don't worry. But I was just going to ask you, how do you think greater geographical narcissism impacts our rural communities, and what sort of things are being done to combat this?
Thanks, Pip. Evening, everybody. I think there's multiple factors here, and realistically, we focus very much on a health workforce and other workforces, but it has to be a more holistic approach. We really need to look at what services are available within communities and ensure that we're capturing that rich fabric that is available in community. I think things like schooling and other family employment is always really important when people are looking to relocate. We've seen some shifts with regard to regionalisation as a result of COVID in New South Wales in certain areas, and I think we've really got to be in front of that in terms of preparation for those that want to move rural. The other thing I would say too is that the holistic approach of the educational lifespan. So looking and considering that we're engaging with people at a younger age, whether it be, you know, through school programs and early entry into university through scholarships, etc., right through to enabling single employment models so that people can have access to a range of experiences within their craft group, and also the ability to be able to be a rural generalist is very attractive, I think, across craft groups. You know, the opportunity to study and to have your qualifications, but then to also look at additional education and training to bring you to a really wholesome and holistic capacity, I think is some of the things that we're very focused on in considering what we can do as far as retention is concerned, and also just that ability to be able to consider that you don't, because you're working rurally, doesn't mean that you have to work in the one spot. You know, lots of small communities are close to each other, and the idea that you might need a half a GP and somebody else needs half, but there might be a regional place close by that can actually engage that person to support them, and then you get that true and much more rich experience, and the communities benefit significantly because you maintain a different level of skill mix, and you maintain, or you really develop a great relationship with multiple levels of the systems and services that are available. Did that answer that question?
That was wonderful. That was very good. My question back
Thank
is,
you.
you know, and Shelley, you might be able to add to this, is, you know, at the moment we sort of see all these different levels. You know, how, so you can essentially work wherever now, but at what point do we need to make sure that, you know, you've got essentially, let's say, the rural health commissioner, you know, making really top of the top decisions, and that's infiltrating down to our grassroots and grassroots right back up again. You know, it is holistic, and we need to have everybody having a seat at the table. Is that happening? Or, you know, how can we make sure that those, you know, change models are occurring? Do you have any opinions there?
Do you want to start,
Go.
Shelley?
There you go, Kat.
You sure? Okay. Thank you. I think at local levels, there's certainly been a lot of work, and we focus our work in particular in developing and supporting individual communities or networks of communities, and that's been quite successful. I think we've out of the box sort of innovative thinking and around models of care and service delivery are really important in this, and just the ability to be able to engage with all of the key health partners that are present or visible in those regional areas to ensure that we are working in a collaborative fashion. You know, the other thing that we have to consider is that regionalisation is sometimes a necessary component of working in a rural area, and that's because there's the finite, you know, finance system that wraps around care in the public system, but at the same time the ability to be able to have those key partners at the table so that you can consider where you might be able to draw some private experience, some aged care experience, and those sorts of things into that. I think that at that sort of more granular level is really important, and that's what informs that sort of town-based or innovative models of care development at that sort of local, sub-regional, regional level.
Do you want me to go?
Yeah, I was going to just jump in.
Yeah. Look, you know, I think there's a bit of a story to be told here. It's not until you really live and work in a rural community that you understand the challenges that the health professional has. They have to have a higher level of cultural understanding from the perspectives of many of the contexts of not just culture from background and ethnicity, but also from an economic point of view. You know, it is well known that rural communities may be a poorer economic state than some of the others, just because the economies of scales in regards to having resources available and different things. It also means the health professional has less people to call on to make that objective critical decision around clinical assessment. And therefore, you know, we've actually expanded their capacity through Virtual Connect and having Dr. Google there to help with, you know, networks of knowledge as well. The third thing is really being able to be competent and confident in decision making. And geographical narcissism, when you're actually relying on a retrieval service support or a second level access to a consultant, and you're not supported from that. Tell me about it. What were you thinking? You know, what's your next decision point? Yes, that's great. You know, move on. It is a continuous global learning phenomena that they have. And then finally, you've got to live in these communities. You run into the same people in the general store, in some of the sporting arenas. So it's being able to also be supported around reflective practice and well-being, so that, you know, there's this mutual respect between patient and caregiver boundaries is more pronounced, I think, in rural regional areas. So, you know, from that broader community expectation, I think above our professional standards, there's these other 4 domains that are by far more important in the eyes of the rural health caregiver than what can be perceived sometimes and often dismissed by other health professionals not working in rural remote areas.
Absolutely. From your experience, JB, did you have anything you wanted to add there, or it's all good if not?
No, I think there's a lot to say on that topic, as can be seen, but I think it's quite interesting that like just rural communities in general is so much more integrated. And as Shelley was saying, you know, you've got that idea of multidisciplinary training within health, but I think it's more than that. It's all the industries, and as everyone was saying, and I think that's where rural, you know, where it kind of loses out, because in the city you've got to divide services. You've got to look at, you know, education and have a whole system for that, and then health and all of that. And in rural, it's so much more closer in a way, and so much more, you know, like everyone knows each other, and you know, if you've got the right teacher and then the right doctor in the town, then suddenly the whole town kind of goes well, and everything kind of progresses from there. And I think those are things that you notice when you go rural. So we, you know, we in Bathurst with my medical student friends, and it's not even that small, and when we go out to karaoke or trivia, you know, like the host is gonna be like, and thank you to our medical students for joining us. Like, they don't even know, like, I don't know who they are, but they know who we are. So it just shows that community spirit in that aspect. That's you know, amazing, and makes us feel part of it, and really shows that, you know, you are part of that community, and you're part of the solution as well.
Absolutely. And I think that
have to own up to something, Pip. And I've been sweating on this, but I have to say I suffer from geographical narcissism.
Continue.
And I've got lots of examples, but the one I'm going to own up to tonight was that experience when I went to that Pacific island. So here I was, 22. I was very smart. I'd finished medicine. I was all over this stuff. And I went to this Pacific island and thought I'll be able to learn some things there and get some good first-hand experience. I'll take modern medicine out there. And when I left there 3 months later, what I really learned was that I was a lot more stupid than I thought. And it wasn't just about the medicine. It was actually about the community. And I thought my family dynamics were pretty sophisticated and pretty stable and all good. But when I went to this place, the dynamics of that community were just amazingly positive. It was a really big network, a big group of families that played and loved and supported each other so well. And I came back thinking, Australia just doesn't cut it in that community. So I learned a lot. I refer to it, I got scarred for life, positively. I've got a tattoo on it. And And it's actually been interesting for me to take that experience further forward. So when I go somewhere else these days, I'm very mindful geographically of being not that white male savior anymore. And it's a real trap. And you have to really have it in the back of your mind, because as you hopefully get smarter and wiser and all that sort of stuff, you'll realize that there's a lot of other people out here who are doing a lot better than you are. And it's surprising where it comes up. And so that was my experience from, years ago. And it taught me a lot of good things, actually. I'm not going to own up to any more, though. I'm still in therapy. Back to you.
No, I think it's very important to own up to these things, because I think one thing that Shelley spoke about, unconscious bias of our nurses and feeling like they're maybe not good enough. And I know there's a concept of clinical courage that is really big in rural health, and being able to say, no, you are good enough. And in fact, you've used all these other skill sets. But another thing to be aware of is, the unconscious bias of geographical narcissism amongst all of us, and being like, oh, quickly, no, I'm not good. And it is something to reflect on in order to change the bigger issue, because it can be very difficult for us to say, do as I say, not as I do, but we all need to enact that. And I think that, Professor Bridham, your experience is a very good way to remember to do that. And I'm glad you're still in therapy with that.
Yeah,
Can I just add it? Oh, sorry, Shelley.
Go, Kath. We're getting excited now.
Yeah, we're all
I
woken
was
up.
just going to, I was actually going to say, as a rural woman who lives in a very semi-remote area, some would say remote, some would say not at all. I think the reality for some is that you don't know what you don't know.
Yes.
And Michael's experience has obviously given him an insight that he's carried with him for his whole life. I think the challenge that we have is getting people to have that experience. And I think that's where our investment really should be focused, is on exposing people to these positive experiences, which, regardless of whether you choose to stay rural, come for a short time, or never return, that it will have an impact on you and an imprint on you that you move forward with. And I'm obviously probably biased in the opposite, if that's a thing. I'll hand over to you, Shelley.
Yeah, look, it is really important to have those experiences. I've worked in Nauru for a very short, it was less than a month, but during that time, just the dynamics of family that support each other and come into, the hospital setting. And, here in most westernized global countries, we expect that, all the hygiene cares are given. Well, many countries, and the ones that are online, know that family come in and do that. And, their ability to extend that assessment against the biopsychosocial needs of their whole family dynamic is just unbelievable, how they bring that together. And then they're not just caring for the patient, but they might pick up that, little one hasn't had immunisation, let's do the immunisation while we're here. We've actually got to pick up on this opportunistic care. It's not like come in, get seen, put the Band-Aid on and off you go. And I think, we're starting to see that dynamic a little bit more in regards to understanding here in Australia, understanding Aboriginal and Torres Strait Islanders. We've got a program in Queensland, the Growing Deadly Families, and it is the family, that you're caring for. It's not just mum having a bub. But, when we make the decision to bring that care into regional or metropolitan area, we're actually upsetting the whole apple cart around, the family care. We're putting little ones at risk because now they don't have their primary care givers, their mum and their dads, and, they're expected to be cared for by aunts and uncles. And what does that mean for, the safety from a child perspective of that one? Moving away from a person who may be a caregiver for an older person. We've got these extended families now. Our decisions that may be called upon from the metro in regards to no, that care can't be provided in that rural area safety, actually put safety in a whole context for a whole family dynamic. You know, if your child is epileptic and your mum's pulled away or your dad's pulled away for, say, cardiac care or other medical care, who's going to be the primary caregiver if, you know, that a person has, you know, an epileptic fit and needs to be cared for in that sense? So, you know, I think for the first time, we're actually looking globally at those you know, sustainable development goals, what it means to have clean water in these towns. And, you know, even here in Australia, there are towns that don't have clean water. And we actually need to actually go back to this and say, as a rural group, as a remote group, we can focus on all of these other things, but let's just all get on the same page and highlight that just because we may not have the same level of resources doesn't mean that we're not deserving of the same level of care. And by pulling health professionals to those towns, giving them great experiences, I think, you know, we actually open up the oyster. And I absolutely think we have a role in playing education both in rural and metro communities, where we bring them together and actually hold some of the workshops out in rural areas, bring the metros to us, and get them to understand what that multidisciplinary context is. We'll prosper. We will prosper.
Absolutely. And I mean, extending that, you know, with education within the health system, yes, but even between industries, you know, looking at the education system alone, you know, Kath identified that, you know, aspects that are both a challenge and a benefit of living in a rural community is employment for partners and the education system. And you know, regionalisation post-COVID has said there's no reason why we can't do that now. And let's ensure that support is required, you know, to make sure that when we do send those people out who have had a positive experience, they don't leave after 2 years because there was a lack of support. Instead, we bring the training to them, like you said, Shelley. I think that's a really exciting idea, and I think we're close. I think good things are happening in this space. I was just going to ask to everyone here. So we're all obviously on the same page, and you know, we've found our tribe in trying to address this. But what is the role of, you know, our nurses, doctors, allied health professionals and administrators who are on the ground in our rural communities daily in advocating for this at a local level, but also how do we alleviate this for those people who aren't necessarily talking about geographical narcissism, you know, at a webinar type situation, but in fact doing the hard yards every day? How do you be your own advocate? JB, you look ready.
Oh, that's a tough question. I think it's a two kind of like two sides of the story, because our health professionals at a local level are very busy already doing a lot of things, so it can be hard to put more expectations and more things on them. But then being, you know, I guess in a role placement and kind of experiencing the community, I realized that the health professionals also have incredible access to a lot of situations and a lot of people that, you know, other professions don't. So, you know, for example, the doctors get invited to the Bathurst 1000, you know, corporate lodge with, you know, ministers and people like that. And so you've got that kind of access to people that are decision makers. And I think it can be easy to forget that that's not the case for everyone else. So in part comes the responsibility to share that aspect and, you know, like raise problems and kind of bring that up to the people that can then do something about it at every level, and making sure that everyone that comes through, and at least training rurally, as we're saying, is increasing, which is great, understands that they are good enough to do anything, and to kind of like build that capacity and that a bit of ego in them as well, and to make sure that they are as competent as somebody who's trained in, you know, the biggest hospital in Sydney. So yeah.
Just by having this conversation, Pip, we're actually myth busting and calling it out. So, you know, you don't hide it under a bushel, as one of my esteemed colleagues would say, but you actually bring it out and chat. And, you know, often what we perceive is happening, you know, from a professional context, by asking the consumers, they will also call out what is good for them and what they're experiencing. So, you know, we can preach to the converted, but it is also about two things that I love to talk about is professional collegiality and professional generosity. And that is about uplifting everybody in that multidisciplinary team to overcome geographical narcissism, but also to overcome geographical isolation, and also to, you know, take a step tomorrow. Go and talk to somebody else that you wouldn't work with outside of your profession tomorrow and say, how do they feel working in that environment and what could be done better for them to actually break down this barrier? So it is also about going outside our circles. I think that would be really important. If we just give everyone the challenge, just tomorrow, find out about a different profession in your rural and regional areas and see how they feel about this subject.
Absolutely. Word of mouth is a very powerful thing. And I think it's probably going to be the thing that changes this narrative over time from things like this, as you said. I also, you know,
I've got a dual diagnosis. I've actually got a complexity that's creeping into me. It's professional narcissism. And I was trying to think about this because professional narcissism, it's a really interesting concept, isn't it?
Look,
Is it a reality?
I would like to think that it could be a reality. We have people talk about authority gradients whereby they're not willing to advocate for patients because they don't feel safe to do that. Now, that's sometimes because of our professional status. That could be perceived as professional narcissism as well, whereby, you know, a nurse may feel not able to speak up. It may be a junior doctor not feeling able to speak up within their own ranks, or to a senior nurse. You know, I think it has existed over the years, but we probably haven't called it out as such. I think it's less than what it's been in the past, but it's like everything, you know. If things are fed and watered, they grow. So unless we actually take back and take the oxygen away from geographical narcissism and professional narcissism, they're never going to go away.
Absolutely.
It's a really interesting thing. Someone introduced themselves to me today and said, I'm so-and-so and so-and-so, and I did some of my training at Great Ormond Street in London. Now, Great Ormond Street in London is said to be the best children's hospital in the world. I challenge that, of course, but it's said to be. So interesting why they put that into their, it was like it gave them street cred. They might have only done a month because I didn't ask them how long. But it was interesting that they put that in because I was mindful of this talk tonight. So I sort of think that that's still part of the process. And we need to think about how to manage that, because I'm not sure if it's ever going to go away, that one, because there's a lot of prestige at training at some of these brands. I keep on my CV that I trained at Harvard. You know, I did a month course there. It was sensational, but it's on my CV because it's got brand value. It impresses people, but it, you know, 30 years later, it probably is irrelevant. But why do we think this, and what is the kudos at some of these big centres, not all of which are, but nearly all of them are metro based, and how do we mitigate that? And do we need to? Because there's something about a perception that if you've got that in your CV, you must be better. And yet I would think these days, I think a rural generalist trained in the rural area, actually a generalist trained in the rural area is going to be far superior practicing than one trained solely metro. And I'm glad this is on recording. I can take the complaints later. But for specialist training, where you have to have a volume curve to get quality, you need a large population to get good at something. So for very subspecialised, I'll call it quaternary services, you actually have to be metro, unless you're in a centre in an unusual place which draws people in because it has reputation to do so. And there's none like that in Australia. So we have this challenge. There is geographical narcissism. I think it is being managed through a whole lot of things that we've talked about. But I think there is professional narcissism, which is going to be more difficult to deal with, I think. And part of it is to do with quality. It's not just about brand. It's partly about volume and quality.
I think it's optics and perception as well. You know, if you just have a look at, you know, our cultures, just by the nature of class and segregation because of that, you know, you have to actually put a title to it to actually get some recognition in some of the cultural backgrounds that we all come from. And, you know, I have colleagues that are in Liberia and Malawi who they walk to their clinics each day and they will walk up to an hour for those clinics to provide, you know, primary health care. And I just look at them with such pride and just think, you know, wow, because you've got all your toolkit in your bag or in your pack and you're going to either, you know, do a maternity assessment of a young mum or pediatric care or look after someone that's aged care. And, you know, that doesn't come with, you know, a big qualification. It comes with a safe quality of care. They have the qualifications that they needed to do that, but they do come with street cred. So, you know, you've got the two sides of the dynamic, haven't you, Michael?
Yeah, I think that issue about having mindfulness about this. And I think, as you said before, having even this discussion about it and opening it up, you would never have had this conversation 10 years ago because it just wasn't in our thinking. But the underlying issue here is I think we devalue a lot of rural issues. They're actually better to train. It shouldn't be seen as, you know, not a great option. It actually should be seen as the best option, but not necessarily for everything. So if you're going to be a left knee surgeon who only operates on X, Y, and Z on Thursdays and Fridays, you're probably better off finding the biggest city you can work in. But if you're going to be a generalist, go where you get the experience and go where you actually practice your art.
And we know that the inverted narcissist is codependent on narcissists exclusively. So, you know, you get this dynamic that they need that relationship in such a way. And that's no different sometimes from the geographical component. You know, when people see that they have this struggle to be identified as a set of equals, they actually also almost become codependent in feeding that relationship because that's the only way they'll get support and resources. So, you know, we've got this counter thing happening as well where we've got to build competence in confidence. It's a bit crazy, but it happens.
Absolutely. I couldn't agree more. I was just thinking that, you know, the conversation is getting quite deep and quite interesting. Does anyone from the floor have any questions? Please do feel free to take yourself off mute, or if you'd like to use the chat function, I can ask it for you. Because it is a very interesting thing. I think you're right, Professor Bryden. I think there's some things, you know, prestige is and history and perception of that may never change, but I think things will evolve, and maybe the end-to-end rural training or increased positive placement experiences will put greater value on those things rather than on the fact that, like, half of Sydney, you also trained at St Vincent's or wherever, you know, St Albans or wherever it may be. I think a point of difference is particularly interesting, and when there is a need. And I do think that, and JB, correct me if you think otherwise, but I think that there is a generational shift in whether it's altruistic, probably not. I think it's a given value of people in healthcare, but I think that there has been a change in wanting to give back to those areas of greater need and choosing pathways based on that. And I'm assuming that most people here tonight would agree with that, and, you know, the conversation starts from here, but it's it is it is perception and something that's very interesting to dissect. Were there any questions at this stage?
And I think for my, sorry, there was Sydney, but I was just gonna say, I think for my part, even if it's not, and as you say, it might not be always altruistic or anything, but I think there's a recognition of the value. So I think now, you know, like 10 years ago, you couldn't have interned as a medical student, do your full internship in a rural hospital. And now you can. Now there's many places to intern at. And we're seeing that in other states that probably have smaller rural hospitals, you know, like WA now having full programs and all of that. And I think that's a massive shift in terms of recognizing value that you can get that. So yeah, I think we're on the right track. All right, questions.
Absolutely. Sydney, would you like to take yourself off mute?
Thanks, Pip. And hi, everyone. Thank you so much for a really interesting conversation. My question, we've kind of talked about all these different aspects of geographical narcissism, and I was wondering if any of you have had experience with geographical narcissism or almost urban favoritism when it comes to grant funding or research funding. We've been told, or we're increasingly told, how important research is for our development as doctors. So yeah, I'm curious from any of you.
I'm happy. There is a reality that a lot of the research funding heads towards metro institutes. But there's a federal initiative, which I think is an outstanding initiative, to increase the co-research arm to rural enterprises. And so just like they're doing with rural schools, they're training rurally, but there has been a very significant difference between the number of researchers per population, metro and rural. So we actually have to build capacity rurally. It's not to say that they're not outstanding researchers rurally. There are some fantastic rural researchers, but in terms of volume, they're more metro based. But the feds have smartened up and they're now making quite a lot of the grants to have either a rural partner or a rural theme. And this is part of that bigger picture of reverse the trend. And I think in the next 20 years, not 20 weeks, there'll be a much better distribution of expertise and then the things that flow from that, papers, etc., etc. But it will take some time. But there's a really good window now for people who might be interested in being rurally researched to get in on that action, because before there's a lot built up, there's windows there for people to be genuine research partners.
Absolutely. Did anyone else have anything to add? Shelley?
Well, there's a question online that I'm keen to focus on. Thank you very much. It was an exciting discussion. You explained from an Australian perspective. Have you experienced when it comes to developing countries, there might be differences? There absolutely is differences, and one of my esteemed colleagues, Professor Joyce Kenkry, who is the second nurse or first nurse with myself on the International Wonka Committee, we have done quite a lot of thought leadership workshops around the voice of the nurse within rural context. And the thematics actually do start to talk about how they may not be given resources for their work, or they don't have the same opportunity. I'm happy to share some of that information. We've got some journal articles that we have written from that perspective. But, you know, the experiences that I see in the South Pacific, here on the Western Pacific region of WHO, we've also seen that in the South African regions as well. So it is definitely there. I think it may just be at a different level or context, but I can't speak to other than my experiences in South America and Nauru and here in Australia. But from our thought leadership, we are gathering the thematics that confirm that, you know, there are experiences, of course, in those developing countries, big time.
Anyone else have anything they wanted to add?
It's a world getting smaller, and I think there's a lot of unfortunate increasing inequities. So that's one of the challenges going forward. How do we consider developing countries and spreading the love a bit more so that we're part of the solution, not part of the ongoing problem for the poor buggers? It's really difficult. So we've got to be front and centre in, giving something up. And that might be sharing some research opportunities or sharing some training opportunities or whatever else. And, this idea of positive discrimination, for our South Pacific neighbours. I'm all in favour of that sort of thing. And it's just not got the groundswell that it should have, to be honest.
Yeah, I think that we are moving towards models which are more hybrid and looking to do, whether it's, placements together or shared research projects or, collaborative events. And perhaps that will become part of that sort of solution and looking at ways to sort of address those things based on our own environments. Dylan, I noticed you have a question. Would you like to go off mute?
Yeah, hey Pip. Thanks all for the discussion tonight. I guess it's a bit of a hypothetical, but I guess a lot of the discussion around promoting rural doctors is decentralizing the training so that you can get it all rurally. But I just wonder if you think there'd be any traction for decentralizing the education component of that. So also like the preclinical years that students have, rather than having to come into the cities to get even the first 2 years, which given Zoom and things like that, I guess the last 2 years have shown that you can do a lot remotely, and given a lot of the tertiary, a lot of the universities have schools rurally anyway, I imagine you'd still be able to conduct assessments in a way that might be conducive with online learning, considering so much of the learning now is already online. I suppose I'm just asking for some thoughts on those, or if it's already been considered by anyone.
Great question.
So, look, a lot of universities are turning their attention to this because it is the way forward. There are some hurdles, not insurmountable, but they are real, like some of the basic sciences teaching in laboratories that have anatomy, for instance. They're not on every street corner. So you've got to think about how to do that. But in the new world of virtual anatomy teaching, there are new ways forward even in that subject. So I do think that in the next decade, virtually all universities will have end-to-end programs that are rurally supplied. The question for us is that the right model? Because a bit like, should it all be metro? I don't think that's the right model. And similarly, I think the whole course being rural is understandably a reaction, but I think probably in years to come we'll think a blended model, which could still be predominantly rural, is the best mix. Because I think if you want to come out as a comprehensive understanding of how the system really works, you've got to have a little bit of that experience at different places. And certainly if you look at the better doctors down the track, they haven't been in one place. They've been in multiple places. And, when I look at someone's CV for a job, if I just see they've been at XXXXX, I question, are we getting a good product here or someone who really understands the big picture? If I see someone who's been rural X, city X, international Y, etc., I go, wow, we've got ourselves a good one here. And I think that it's the way you build that bigger picture of what doctors are about. Part of its resilience, part of its experience in other cultures, part of its experiencing different environments in which to work medically as well.
And I think to follow on to what Michael was saying, I agree to an extent now with the experience I'm seeing with the new end-to-end programs coming through. I was really excited by end-to-end program because I think it's fantastic. Like somebody doesn't have to move to Sydney and they can become a doctor, and that's just awesome. But I think considering size factor does matter, I think, because, you know, if you're going to get all of your surgical teaching or all of your medical teaching from maybe one or two practitioners, that maybe does restrict you in a way in terms of like just varied exposure and practice and where you're doing things. Like you might get a really good experience or a really bad experience. And I think the way the Metro model kind of works is that obviously you get repeated exposure to different supervisors, which then kind of, I guess, even out things. So you can kind of like have a more moderate experience. And I think also in terms of networking, having very small cohort in small places the whole time might limit the opportunity for those doctors that are going to be rural. And we know how important networking is. And if they do spend a year preclinical in Sydney or in Melbourne, or they're going to meet, you know, 300, 400 medical students all at once, and all those people will be the future doctors. And that is invaluable in a way. So I think, I think what Michael was saying is right. I think the blended model, I think with a strong emphasis on rural for people that want to go rural. So again, staggering that, maybe exposing everyone to a little bit of it, and then furthering that education is probably where it's going to be most relevant.
And just
And
to add,
sorry.
Shelley, you go.
Life circumstances change as well. And, you know, sometimes blending your needs around life circumstance is really important as well, because, you know, we give to communities our lived experience, and particularly around a little bit of metro, a little bit of regional, a little bit of rural, you know, makes the best of all worlds.
And I think this is a little bit of see how we go. It's not going to be perfect science, but there are countries in the world where I don't touch their university medical graduates in some of their universities. Some of them produce out. Some of the universities in that country, they're on a list, they're good, but don't touch these ones over there because there's a second class of university product. I'd hate that to happen in Australia. I think that would be a terrible outcome if somehow the end-to-end rural products tended to then be seen as an inferior product. That would be a really big disaster. So we've got to prevent that by making sure the standard is one standard for everybody. We've got to make sure that the perception as well as the reality is managed. And I think the best way to deal with that is this blended model.
It's an interesting discussion. I think it's, you know, definitely watch the space. And the thing is, with hopefully as it evolves with, you know, continual reviewing, then we can ensure that, you know, things don't fall below standards that are acceptable. Harry, I notice you have a question. I might take to you, and then I've had one sent through online. So we'll do two more. But I'll go to you now, Harry, if you'd like to take yourself off mute.
Awesome. Thanks for tonight, guys, and Pip for organising. I just wanted to ask a question in terms of, do you think we need to be careful about over kind of promoting rural in a way that, I think from my experience so far in med school, is a lot of people, they want to get the best experience. They want to get the qualifications, which will put them above other students. It's quite a competitive environment. How do we avoid saying, you know, rural is the best place to get training, and then you're going to be above your colleagues, and actually promote it in a way that wants people to go out there for the experience and for the people and the community versus just for their own CV in a way?
Yeah, Harry, I think what we've matured on is having pathways for careers. And, you know, I guess speaking in my profession, we know that you can have a clinical career, you can have a managerial career, you can have a research career, you can have an education career, you can now have an informatics career. And, you know, it is about just mapping out what's for the individual and taking the best of what's available in regards to suiting your direction and who you want to be. And not everybody wants to be a rural generalist. Not everybody wants to be a consultant working in metro environments. Some want to be a mix of everything. And I think how we actually ensure that we don't undermine one or the other is that professional collegiality, that we understand that there's different horses for different courses, or different courses for different horses, and that we actually respect people's decisions, but we also be very open and transparent of mentoring and giving good advice when it's required, and also very frank advice around that career trajectory. You know, we're lucky here in Australia, we have the Rural Generalist Pathway, but we also have colleges that represent pathways to become a paediatrician, to be obstetrician, all of those sorts of things. So your points are valid, but I think it is about, you know, taking the individual aspect of what you life and what you want to give to medicine or nursing or midwifery or allied health.
Yeah, I couldn't agree more. I think we'll go to our final question, which has been sent through, and it says, does the panel have any concern that health policy is led by potential geographical narcissists? And if so, how much of a barrier is that, and how can we work around it? So a bit of a dense one to finish with. Any takers to address that straight away?
Well, at the end of the day, I think we can inform policy and future policy and practice in rural health by being generally aware of this phenomenon. There's going to be some people that are going to be more obvious than not. But I think, again, as I mentioned before, actually having these discussions, we're bringing it to light, we're myth busting, we're calling it out. You know, often it is a bias and often subtle and unconscious. So having these decisions gives some self-reflection, like Professor had said before, you know, that he's, you know, had some experiences of where he has, you know, been an individual participant. But at the same time, I think, you know, it's got to come down to ensuring that we have the discussions so they don't continue to be barriers, and, you know, we continue to innovate models of care in rural services, in regional services and metro services with the best health professionals and the best multidisciplinary teams, that we all prosper.
Absolutely. And sorry, JB, you go and then I'll jump in.
No, just giving my perspective, I guess, from last year being the chair of the NRHS, and I got to meet a few people that were, you know, involved in policy making and things like that. And I guess my preconception was probably that there was like prevalent narcissism and everything was, you know, like the whole Canberra bubble of whatever people call it. But I think I actually realized that most of them just want to do the best they can, but often they might not know how or which direction to go to. And I think that's where rural kind of comes in play and can feed that back, can be present and give, you know, have a louder voice than they already do, to kind of get heard, and navigate the, you know, the whole system in the world maybe better or differently to kind of get the outcomes that we're looking for.
Yeah, absolutely. Kath, did you have something you wanted to say?
Yeah, I did. I just wanted to add to that I think it's actually important that policymakers and funders alike are exposed to the rural experience. You know, we see with innovative models of care and the way that we're working at the moment that being able to actually report on something or present something loses its context if it's not in its environment, and the ability to be able to draw people into regional areas and rural areas in order to understand firsthand some of those experiences has been absolutely outstanding and has given a real level of depth in policy writing, but also in I think interpreting that policy for funding opportunities. And I think some of the funding that's come through from the Rural Health Commissioners, models of care, etc., is testament to that. It's about getting those people out there and having them exposed to that experience, and then wrapping it up, you know, with the expertise that we can draw on to enable a really good outcome.
And thanks, Kathy. And I would just add, not to be a dampener, but I do think most of the bureaucrats I've worked with in the past understand the consequences of making change and think through in the longer period, if you do X, something over there is going to change, and you've got to think about that as well. what worries me is more of the politicians don't think about over there too much if it's beyond their political 5 or 3 year cycle. And that's one of the dangers. So more of the people, if you like, managing the services and planning the services actually get it. My worry is that the politicians with short-term milestones to keep, I got to get back into politics, and they'll do anything, some of them, to stay there. And they're looking for the quick wins, which is not necessarily the best long-term investment. And that's a challenge, actually. And it still worries me a fair bit that you have those sort of short-term cycles too frequently running the show.
Yeah, I agree, Michael, and I think one of the biggest challenges that we see in operationalising our rural health footprint is the ability to develop relationships within departments which do rotate and change every 3 years, you know. So you're building a relationship, you're engaging well, you've got people on the pathway, you educate, you immerse them, and then lo and behold, the 3 year stint's up and it rotates again. And the same with funding. You know, if you've got finite funding rounds, that it makes it extremely difficult to have that level of consistency and longevity. But having said that, I think that there are definite actions and activities towards change in that space too.
Absolutely. And I do think, as JB said, there are a lot of people at the moment, you know, politics aside, that are there for the right reason and moving into jobs in this space because people are ready to stand up and speak up. And I think, as Shelley said, the conversation starts here. And the more of this that happens and the more of this that continues to happen after this webinar, and, you know, whether that goes to the, you know, our government, non-government organisations, I think that, you know, sustainable change is close by and it's happening at the moment. So hopefully good things are coming our way. On that note, I think we will wrap up just in the interest of time. Thank you, everybody, for attending. Thank you particularly to our wonderful panelists. We all really appreciate your, you know, diversity, your depth of experience, knowledge and wisdom. And it's been a really interesting conversation. As I said, it has been recorded. So if anyone would like a copy, please get in touch. Also, if anyone would like to know more about Rural Seeds or to become a part of it, please also get in touch. There's a few of us online tonight, or you can contact me. I know a few of you have been in touch with me about rurally based things before. So thank you all. I hope you have a wonderful rest of your evening or morning, whatever time of the day it is. And as I said, this is a series of rural health webinars. So I will make sure that you'll all receive the next one, which will be in a few weeks' time. When we have further details, I'll send those through. So thank you all so much, and look forward to seeing you at the next one.
Thank you, Pip. Great session.
Thanks, Pip.
All the best.
Thanks.
Thanks, Michael.